All right. Good afternoon, everyone. Welcome to today's edition of the MQ Health Wellness Series. And today we'll be talking about men in cancer, screening, prevention and treatment. My name's Dr. Darran Foo and I'm one of the GPs here at MQ Health. And I would like to start off with an acknowledgement of country, which we will get to now.
Welcome. We acknowledge the traditional custodians of Macquarie University land, the Warramadigal clan of the Darug Nation, whose cultures and customs have nurtured this land since the Dreamtime. We pay our respects to elders past, present and future. We welcome people of all nations and all faiths. Kwai Bidja, Jamna Payala Janawi. Come here, we speak together. We have 60,000 years of archaeological evidence of Aboriginal habitation at Lake Mungo and 20,000 years in Ryde. We have great antiquity. Today, hundreds of Aboriginal and Torres Strait Islander people graduate from Macquarie University. The Darug Nation had famous leaders such as Chief Yarramundi, Naraginji, Colby and Maria Locke. Many of the descendants of these Darug people live today amongst you. We celebrate with you our ongoing attachment and custodianship of this country. We celebrate the achievements of Macquarie University.
All right. So today we have a lineup of speakers to talk about this topic, men in cancer. We'll start off with myself, giving a bit of an introduction. We have Dr. Jaiti Khosla, Dr. Henry Cheung, and we also had Dr. Benjamin Namdarian on the roster, but unfortunately he has been called away for an emergency, and we will record and upload his talk and make it available at a later date separately. So I'll start off today's series by talking about an introduction on preventable causes of cancer and the importance of cancer screening for men. So some quick stats about cancer in Australia and why it's important to talk about this today. So it's estimated that roughly 2 in 5 Australians will be diagnosed with cancer before the age of 85. And more than 160,000 new cases of cancer are estimated to have been diagnosed in Australia last year in 2022. And it's an average of 400 plus diagnoses a day. So most people in Australia will be touched by cancer at some stage in their lives, either personally or through family and friends. But the good news is that the survival rate for many types of cancer has increased by more than 20% over the last few decades. This is due to treatment improvements and new interventions brought about by new research. In terms of men and cancer, some quick stats about men in cancer and why it's important to talk about men in cancer today. So we do know that men who have been diagnosed with cancer don't fare as well as women. They have around 4.5 years lower life expectancy, they have poorer health in their last 10 years of life, and they have less chance than women of being alive 5 years after being diagnosed with cancer. It's estimated that 1 in 2 Australian men will be diagnosed with cancer before the age of 85. And in general, men have more risk factors. This includes higher rates of smoking and alcohol use, higher rates of obesity, having poorer diets and lower levels of physical activity. And men tend not to go to their doctors to discuss changes in their health or symptoms. So how can we reduce the risk of cancer in men? And when we talk about cancer in men, it's not just about prostates and testicles as commonly we would think about immediately. The most commonly diagnosed cancers in men are prostate cancer, followed by melanoma, skin cancer, then bowel cancer is number 3, and lung cancer is the 4th most commonly diagnosed cancer in men. How can we reduce the risk factors for developing cancer? And there are some common risk factors that play a part in increasing your risk of developing these cancers. And research has shown that 1 in 3 cancers can be prevented by living a healthy lifestyle and trying your best to reduce your risk in regards to these common risk factors that apply to all the different types of cancers that may affect men. So these include being smoke-free and limiting or avoiding the amount of alcohol that you drink, maintaining a healthy weight, eating a well-balanced diet, and having 30 to 60 minutes of moderate to vigorous physical activity a day, and having regular and appropriate cancer screening tests. Now I'll move on to talk about some of the specific screening and preventative measures for each of these top 4 cancers that we see in men. Firstly, I'll talk about lung cancer. And lung cancer presents most of the time quite vaguely, and usually as a cough that's not been going away for a while. Although many other things can cause coughs, if you do have a cough that you find hasn't gone away for a while, for several months, or if it's showing blood, or you have a hoarseness that persists, then please go and see your GP and discuss this with your doctor. In Australia, there is a new national lung cancer screening program that is being announced and will commence in July of 2025. And this is quite exciting because this is the first new national cancer screening program in nearly 20 years in Australia. This program will target high-risk individuals to detect lung cancer in its early stages and will look to increase the likelihood of successful treatment and improving lung cancer outcomes through early diagnosis. Next, I'll talk a little bit about bowel cancer. And generally, if you're having, bowel cancer can be picked up through screening programs, as we have the National Bowel Cancer Screening Program, but also people can sometimes present with symptoms relating to change in their bowel habits. And so if you're noticing that you have blood in your bowel motions or persistent change in your bowel habits, then please discuss this with your GP and seek some advice from them. The National Bowel Cancer Screening Program is the national screening program for bowel cancer, and that's been around for some years now, and is eligible to all Australians aged from 50 to 74 years old. And this is done through a test that's mailed out to you and free of charge, and it's done at home every 2 years. Do note that screening recommendations may differ depending if you have a family history of bowel cancer or other risk factors that may predispose you to having an increased risk of bowel cancer. And so you should talk to your doctor if this is something that you have a history of. The next thing I'll talk about is melanoma, which is a type of skin cancer. And generally, melanomas are picked up by GPs or dermatologists. Most people will tend to notice a mole that maybe have change in shape, size, or color, or start to bleed, or have inflamed skin sores that are not healing. And so if you notice any of these, do discuss this with your GP as well. There are no national screening programs for skin cancers and melanoma, but generally we talk about good skin care and sun protection and using the 5 S's of sun safety, and also having regular skin checks either with your doctor or by doing self-checks. And the next one to talk about is prostate cancer. And generally, people can present with symptoms regarding changes in urinary behaviors. And so if you have changes to your urinary stream or other urinary problems or changes, then you should talk to your GP about this. And there are some tests that we can use for prostate cancer screening. One of the commonly known ones is called the PSA blood test. And you should discuss this with your doctor if this is appropriate for you. And last but not least, I'm going to cover off on testicular cancer. That was not one of the 4 most common cancers, but it's commonly one of the cancers that we think about when we think about men in cancer. Testicular cancer in general is rare, but is one of the most common cancers in younger men aged 15 to 45. It is also one of the most curable cancers if found early. So the main thing to note is just be aware of what is normal for you. And if you see or feel any changes, you should book in to discuss this with your GP, and don't let embarrassment get in the way. All right, thank you for your time. Now I'll pass on to my colleague, Dr. Jaiti Khosla, to talk about skin cancer screening and treatments. Jaiti completed her medical degree from the University of Newcastle. Prior to training in general practice, she worked at Canberra and Westmead hospitals, and she also has experience in rural emergency medicine. She has completed the Certificate of Dermoscopy from the Skin Cancer College of Australasia and is currently undertaking a Masters of Medicine with a focus in skin cancer from the University of Queensland. Dr. Jaiti is very passionate about her work in skin cancer and takes pride in providing care of the highest standard. Outside the clinic, her hobbies include exercise, dance, and drama. I want to hand over to Jaiti.
Thanks a lot, Darran. As Darran's already introduced me, my name is Dr. Jaiti Khosla. I am a skin cancer GP here at Macquarie University Health, and I'd just like to say thank you for this opportunity to discuss this very important topic and subject with you in Men's Health Awareness Week. All right, skin cancer screening and treatments. Now, I've put up some common statistics about skin cancer and melanoma. Unfortunately, across the globe, we are the gold medalists and we have the most common, the highest rate of melanoma in the world. This is something really not to be proud of, and there's a lot of work to be done, but I know we'll get there all together if we really focus on this very important topic. As you can see, it's melanoma is number 2, as we said, of the most common cancers that occurs in men after prostate cancer. And if you combine the statistic and include non-melanoma skin cancer is the most common cancer that occurs across Australia. As you can see, there is a disparity in both non-melanoma skin cancer and melanoma skin cancer, and men are more likely to get both when compared to women, and they're also more likely to die of melanoma. Why these are some of the postulated reasons why the disparity may exist, and you often wonder why Australia. And there's a lot of factors here that are not in our hands. As you may know, a long time ago, we migrated from Africa and moved into parts of Europe. There is a theory that the darker pigmented skin was actually a hindrance to absorbing vitamin D, and so the skin of those the people who lived in those areas became lighter. And more recently, we've had migration into Australia from all those parts of the world, and that fairer light skin is not suited to the harsh UV rays that we often face every day in Australia. Also, due to our geography and where Australia is, during our summer months, we're just a teeny tiny bit closer to the sun, around 1.7%, but even with that, we get much more UV rays, increasing it by 7%. So there's a lot that we can't change, and obviously we have very little pollution in our air, so we don't want to change that as well. Another reason why we could think that men get more skin cancer than women is the lack of sun protection. There's some studies by the Skin Cancer Council that show less than 1/3 of men actually use regular sunscreen, and around only a half will choose to seek shade in the summer months. Men are generally less vigilant about skin cancer checkups. Often I get couples that come to me and the husband has been dragged in by the wife, and they are not really wanting to be there. They're just sort of there because they were made to. So they take this a bit lightly, and that can be quite dangerous. Occupational exposure is a huge risk factor for developing skin cancer. Obviously, the more time you spend in the sun, the more time you get burnt, that will all increase your chances of developing cancer. And unfortunately, occupations such as agricultural workers, farmers, labourers, truck drivers all have a lot of time that they need to spend in the sun to make their living. So this is the most common types of skin cancers that you may hopefully not get, but you may hear of. Obviously, the most dangerous one is malignant melanoma. Every melanoma, if left untreated, can be deadly. The non-melanoma skin cancers, the two most common ones are basal cell carcinoma, or BCC. The metastatic potential, or the chances this is likely to spread all over your body, as you can see, is quite low, but locally they can be quite destructive. So if you have something that is let go and not treated early on, it can get larger and larger and start destroying structures around it and impairing the function of certain parts of the body. Also, it can get infected and cause cellulitis and infection throughout your whole body, which can also be very dangerous. So it's important to take these out when they're small and with as little surgery as required. The other common non-melanoma skin cancer is squamous cell skin cancer, also known as an SCC. As you can see, it's a bit more likely that this may spread all over your body, especially if it's diagnosed on the head and neck, and has a chance of unfortunately leading to death as well if left untreated. There's a few very rare skin cancers that I haven't mentioned. I've put this slide up to just show the variety of skin lesions that we can have. If you look all over your body, you'll notice that there's things that are quite pale and things that are quite dark. Unfortunately, if you don't work in this field or haven't had something like this before, it's really difficult for you to pick up which one is a cancer and which one is benign or can be left alone. And you can have a look here and try to guess which ones you think would be skin cancers, and I can assure you you won't be able to get all of them because they can be quite sneaky. So these ones I've highlighted are all skin cancers. The top right is a well-differentiated squamous cell carcinoma. The bottom right is a hypomelanotic melanoma. And the top left is a lentigo maligna. So it's tricky business, and it's really important that as a patient you become aware of your skin and learn about it and know what's what. So prevention is key. As I mentioned before, there's a lot of independent variables that we can't change and we cannot do anything about, like where we live. But something we can do is as easy as slip, slop, slap, seek and slide. It doesn't get more straightforward than that. We need to protect ourselves every day, whether that be winter or summer, as every minute counts that you spend in the sun. Often people will put some SPF on their face but forget about the rest of their bodies. This can be quite dangerous, as if you're not covered up completely, you will be exposed to the UV rays and sunlight. So common areas that do get missed are the back of the hands and forearms, and these are always often exposed throughout the whole year, for example when you're driving or may just be out and about. So it's important to put SPF 50 or 30 everywhere that is not covered up. There are UV index apps that you can use. For example, that might be useful for someone who would like to check the UV rays on a particular day and see if it's a good day to go out on the beach or not, or maybe another day would be better. This can be useful, but if you really want to keep it very simple, I highly suggest you just remember these 5 every day, especially applying your sunscreen. And lastly, I'll talk about becoming skin aware later in my talk. So things you can look out for, that's quite a good list of things you can watch out for on your skin. But I like to keep it very simple for my patients. Anything new, anything changing, anything you're unsure of what is that? What is that? I don't know what that is. I'm a bit worried, but I don't know if I should see a doctor. Just keep it simple. Go see your GP or your local skin cancer specialist and get it checked. Because as we discovered previously, it's really hard to pick up and something should just not be left alone if you're not sure what's going on. Lastly, I'd like to talk about skin checks. This is a very easy preventative measure as well. Normally, a skin check only takes 15 minutes. It can take a bit longer if you have lots of lesions on your skin that we need to examine. It should always be done with a dermatoscope, as you can see in that photo, because that's really essential to looking very closely at the structures that are involved. Normally, the doctor will look head to toe, all over your skin, and this is actually a fantastic opportunity to ask questions. A lot of my patients will point to something and say, oh, what's that? I've had that for a while. Is that okay? What's this? This is new. And during this process, you'll actually learn more about your skin and understand what's normal compared to what's not. And during a skin check, we normally mark out the lesions that we are concerned about. Sometimes you might need a little biopsy to see what this lesion is, because that's the only way to know whether a skin spot is a cancer or not, is to take it out, send it to the lab and have a look under the microscope to see what the cells are doing. This is a snippet from the Red Book, which is the main our guide that we use for preventative medicine here in Australia. As you can see, I'd just like to point a few things out. Definitely take note of the high risk column. If you're high risk, you need a skin check every 6 to 12 months. And that point about 5 atypical nevi, if you have more than 5, you need a skin check every 6 to 12 months. As a layperson, that's really difficult to know which one of your moles is dysplastic or not. Even as a doctor working in the field, you can't know just by looking at it. So if you have lots of moles, you're automatically at high risk, and you should, or not automatically at high risk, but you may be at high risk, so you should get checked up. The other thing I'd like to point out is men are already in the increased risk column. Just by being male, you're considered higher risk. And the advice there is to get a skin check opportunistically. So I would encourage everyone today who's watching, this is your opportunity, book a skin check in. Once you get one, you can actually ask the doctor how frequently you need it. They might be able to advise you of, based on your risk, how often you might need to come in. But the thing I'd also like to point out is if you have had a skin check within the last 1 year, but you do notice something that is still on your mind and you're still worried about, it's important to go back and be proactive and get it checked, because sometimes it can happen that we look at something and it looks quite benign and normal in one stage, but in a few months it's changed a lot. And if you don't come back to us, we will never know. So make sure it's really all about being proactive and learning about your own skin type. And learning how to do a self-check, which we can teach as well. This is a quick slide on treatments. On the left, you'll see what treatments are available for early skin cancers. Something like liquid nitrogen therapy, where we freeze a cancer. You can get a small biopsy or a small excision done of a skin cancer, and you just cut it out just in the rooms under local anesthetic, or there is some creams available as well. On the right, you'll notice that it's a much larger, more extensive process for treating larger skin cancers. Sometimes you need to be admitted in the hospital, you need to go under general anesthetic, and you may need biopsies of your lymph nodes, plus also radiotherapy. And the idea is stay on the left. We want you to come early. We want you to have as painless and as cost-effective procedure, so you can avoid, obviously, the later complications that can occur. So my take-home messages: number 1, be sun smart. Every minute counts. Number 2 is to get checked. And number 3 is to get educated about your skin. Knowledge is always very handy. And a few myths that I can, sort of get rid of at this point are that you can only get skin cancer in sun-exposed spots. That's actually not true. You can get skin cancer anywhere from your head down to your toes, in your genitals. You can get skin cancer under your nails. You can get skin cancer in your mouth, even your nose and your eyes. So there's just because you think, oh, that spot's never seen the sun, it'll be okay. It's not actually the case. Also, I'd like to encourage younger people to get checked as well. you can get skin cancer at any point in your life, and unfortunately, it's the most common skin cancer that occurs in the younger adults. So I'd like to leave you with those few pointers. And once again, thank you so much.
Thank you, Jaiti, for that wonderful, insightful talk on skin cancer prevention and treatments. Now I'd like to introduce Dr. Henry Cheung. Henry is a Colorectal Surgical Society, Australia, New Zealand recognised specialist colorectal surgeon who provides comprehensive care in all aspects of colorectal surgery, from colorectal cancers to anal rectal conditions, as well as general surgical conditions such as abdominal wall hernias. He has extensive experience in minimally invasive surgery techniques, including robotic surgery. His philosophy is to treat the patient and not just the condition. He is an integral member of the tertiary multidisciplinary cancer care teams and offers cutting-edge treatment options at Macquarie University Hospital and Concord Hospital. I'll hand over to Henry.
Thank you, Darren. My name is Henry Cheung. I'm a specialist colorectal surgeon, so I guess let's get right into it. So bowel cancer is also known as colorectal cancer, and the differentiation really depends on whether it is involving the colon, so it's known as colon cancer, or rectal cancer when it's involving the rectum, highlighting in red. Bowel cancers start as benign, non-threatening growths called polyps, which grow on the inside lining of the bowel. And polyps can vary in size from a few millimeters to up to a few centimeters in size. Whilst polyps are generally benign and harmless, if they're left undiagnosed and untreated, they do become cancerous. In Australia, bowel cancer is one of the most common cancers diagnosed, behind prostate, breast, and melanoma. In fact, bowel cancer is the most common cancer diagnosed that affects both male and females. In Australia, roughly around every year, 15,000 patients are diagnosed with bowel cancer. In New South Wales, we estimate that 1 in 12 men will be diagnosed with bowel cancer during their lifetime. 91% of bowel cancers were found in those who are 50 or over. So bowel cancer is also known as a silent killer because it can develop without any symptoms until it has reached an advanced stage. Around 5,000 Australians die from bowel cancer each year, and in men it's the second deadliest cancer. A common misconception is that bowel cancer only occurs in the elderly. Early onset bowel cancer has actually increased steadily, where now 1 in 10 bowel cancers are diagnosed in those under the age of 50. It is also the deadliest cancer and 6th leading cause of death amongst Australians between 25 to 44. There is a trend towards more left-sided colon cancers and rectal cancers in particular. Hence, they are more likely to experience symptoms, but often these symptoms are attributable to other things like hemorrhoids, poor diet, busy lifestyle. So by the time that they seek help, often the cancer is more advanced stage. So if we look at nowadays, a 45-year-old has same risk as a 50-year-old 10 years ago for developing bowel cancer. So what increases one risk of developing bowel cancer? So we discussed risk factors as whether they're modifiable or non-modifiable. So things that we cannot change are non-modifiable, and that includes age, family history, and certain genetic conditions. Like many health conditions, the risk of bowel cancer increases with age, and the increase is most significant for bowel cancer after the age of 50. Around 30% of patients who develop bowel cancer have either a hereditary contribution, family history, or combination of both. But the majority, other 70% of patients, do not have any family history of the disease or heritable conditions. So generally speaking, the more members of the family have been affected by bowel cancer, and the younger they were diagnosed, the greater the chance of a family link. Hereditary conditions due to genetic mutations account for a minority, around 5 to 10% of all bowel cancers overall. These are the most common conditions, but we won't go into them in any details. Then there are modifiable risk factors, and as Darran have pointed out earlier in his presentation, smoking, consuming processed and red meat, excessive alcohol consumption, obesity, and having an inactive lifestyle are modifiable risk factors that we know for bowel cancers. Other medical conditions such as type 2 diabetes, inflammatory bowel disease, and certain rare syndromes can also increase one's risk of developing bowel cancers. So the symptoms of bowel cancer can develop rather slowly over time, so they may not be obvious until the cancer has become advanced. The location of the cancer also determines how likely these symptoms may present. So cancers that are more close to the anus, such as the rectum, are more likely to be symptomatic earlier. And I think one of the most crucial take-home points is what are the red flag symptoms. There are several symptoms, and the first one is blood, and that includes any color or amount of blood. So regardless of whether it's bright red, dark red. A change in bowel habits, such as new onset constipation, going to the toilet more frequently than usual, feeling incomplete emptying, and also a change in the shape and consistency of stool. Late symptoms might include abdominal pain and feeling bloated in the abdomen. Or patients may have unexplained anemia that's found on a routine blood test, and also iron deficiency. So how is bowel cancer diagnosed? The diagnosis requires a colonoscopy, which is a telescope examination that is inserted under sedation in a cleansed bowel. At the time, if we find any abnormalities such as polyps, it can be removed, or any suspicious growths be biopsied for further pathological confirmation. Whilst colonoscopy is the gold standard, other adjuncts in detecting abnormalities concerned include stool test, blood test, and also radiological scans such as CT scans are used in the staging of bowel cancer once confirmed. So bowel cancer is staged based on how far the cancer has spread, and these are divided into stage 1 to 4. And it essentially determines whether someone has early stage, locally advanced, or metastatic cancer. The idea behind screening is to detect the problems early when one has no symptoms. While no test is perfect, regular screening increases the likelihood of diagnosing the problem and improving the chance of survival. In Australia, we have the National Bowel Cancer Screening Program, where fecal occult blood test kits are mailed to Australians between the age of 50 to 74 every 2 years. The idea behind the blood test is to detect blood that one cannot see. In the kit, you will have everything that you need to perform the test in the comfort of your own home. And nowadays, there are very simple to follow online resources that actually explain how you do the test. Outside the screening program, anyone can also request having a FOBT done. You just need to approach a GP who can request the FOBT for you. So what does the result mean? So when you have a negative result, that means no blood is detected in the sample provided. It does not guarantee that no cancers or polyps are present, but it does make the likelihood very low if performed correctly and repeated every second year. However, if the result is positive, that means blood, and that can be blood of any source, has been detected. It must then be followed up with a visit to your GP, who then refer you on to see a colorectal or gastroenterologist to obtain a colonoscopy. Some patients may have colonoscopy screening due to family history or conditions that increases their risk of bowel cancer. There's also this thing called CT colonoscopy or virtual colonoscopy, where using CT technology, the bowel is reconstructed, but this is really more reserved for patients who cannot undergo a colonoscopy for various reasons. The second crucial point is when bowel cancer is detected early, it is curative and it can be achieved with surgery alone. As the cancers become more advanced, then the treatment pathway is often not as straightforward. So for cancers to be curative, Surgery is the first-line treatment, and it involves removing the segment of bowel where the cancer is, as well as surrounding tissues, especially the lymph nodes, as a complete package. When cancers are diagnosed early, they're more likely to be able to be performed using minimally invasive techniques, such as laparoscopic surgery or robotic surgery these days. There are situations where advanced or metastatic cancer surgery may still be performed, but these are probably done to relieve the patient of symptoms or to reduce the cancer burden from the advanced disease. One of the most common questions I get asked when patients confronted with diagnosis and surgery is, will I need a stoma? So a stoma is basically where the bowel is brought through the abdominal wall and drains into a bag. And a permanent stoma, it's usually not likely unless you have a cancer where we cannot reconstruct joining your bowel back together. Temporary stomas may be performed in certain situations, such as if it's to improve the healing of the joint, if patients are of medically high risk, or patients who have undergone an emergency cancer operations. Other treatments such as chemotherapy and radiotherapy are used in selective cases. Chemotherapy is where there is evidence of cancer spread beyond the bowel, and this may be given before or after surgery, and in those who cannot have surgery due to advanced nature of the cancer. Radiotherapy these days are specifically given for rectal cancers in the more locally advanced setting, where it's used to reduce the likelihood of the cancer growing back in the pelvis, or in some cases we are using it to reduce the patient's symptoms or when the tumor is difficult to remove by surgery. So as we said earlier, the earlier the cancer is detected, the better the cure and therefore the prognosis. If we look at the graph in men, if you have a stage 4 bowel cancer, your 5-year chance of surviving the cancer is around 13%, as opposed to stage 1, which is the earliest stage of 97%. While there is no foolproof way to prevent bowel cancer, there are several steps that men can take to reduce their risk, and these include being active, maintaining a healthy weight, drinking alcohol less excessively, not smoking, be mindful about reducing the consumption of processed and red meat, having a diet that's high in whole grains, dietary fiber, dairy products, and also being aware of your family history and definitely participate in bowel cancer screening. There are minimal medications that have been shown and can be recommended for bowel cancer prevention. The only one is probably low-dose aspirin, but this must be in a setting where you've been advised medically, because there are certain situations where patients can't have aspirin. So the take-home message is that bowel cancer is a serious disease, but it's also a preventable disease. Living a healthy lifestyle, participating in screening program is a major part of prevention of bowel cancer, or at least to be able to detect it early and at a curative stage. So if you are aged between 50 to 74, make sure you undertake the National Bowel Cancer Screening Program every 2 years whenever you get the kit mailed to you. If you have any symptoms or concerns, regardless of your age, go and see your GP as soon as possible because you might need further investigations. Once again, really can't emphasize enough the importance of early detection, which is the key to successful treatment and ensuring the best outcome should you have been diagnosed with bowel cancer. Lastly, in our community, help is always within reach. Your best source is your friendly GP, but there are also a number of organizations with high quality resources online that you can access at any time. Thank you very much.
Thank you, Henry, for that wonderful talk on bowel cancer screening, prevention and treatment. And the good news is that we do have Dr. Benjamin Darran here with us, out from theatres. So I'll introduce him. Benjamin recently returned from London, having worked as a consultant surgeon in the NHS at Guy's Hospital after completing prestigious fellowships in robotics at Guy's and St Thomas's Hospital and adolescent transition reconstructive urology at the University College London Hospital. Ben has a keen interest in technology, particularly robotic cancer surgery and reconstruction, advanced prostate cancer diagnostics, personalised care with enhanced utilisation of technology such as Urolift or green light holmium laser prostate surgery. and adolescent transition urology for congenital disorders. Without further ado, I'll hand over to Ben.
Good afternoon, and thank you for that introduction. I've just ducked out of theatre, so hence my attire, so apologies. But thank you for the opportunity to speak on another important area, particularly in men's health, and I've been asked to talk on the areas of prostate cancer, particularly screening in new developments, as well as testis cancer, so the two common men's cancers that we see. So we'll hopefully cover that, the rationale for screening in prostate cancer and some of the debates around that, and some of the newer techniques that are being utilised to diagnose and treat it, and then looking at testis cancer and what populations it's important to consider this in. So this is a common question that urologists are faced with, and I know that colleagues ask this in GP colleagues, and other colleagues ask about who should we actually be doing PSA screening. And so the typical person is someone in their 50s or 60s who doesn't have any particular findings on an examination, if it's been done nowadays, and no family history. And what is the role of screening there? So I think that's actually the wrong question. I think we are probably guilty of the problems with overdiagnosis and overtreatment as urologists and clinicians in the last 20, 30 years. And what's more important is that we get an understanding and diagnose patients, but uncouple that from treatment itself. So finding out about cancer is important, but then actually what's more important is knowing what to do and minimising any of the morbidity and challenges we see with that. And this is quite clear on probably the best screening study that's been performed out of Europe, the ERSPC, and then there's a sub-study out of Sweden with the mature data. And we don't see these results unless it's over a longer period of time. So it's a disease that causes issues over the 5 to 10 year period. And so we can see at the 18-year point of this study with the mature data that there's a significant reduction in mortality for men that are screened. But what's important is that we're looking at men that have significant prostate cancer, not those that are going to have a more indolent path. So we really need to separate diagnosis and screening, which I think is really important in all diseases, from the treatments and the morbidities that is associated, and only treating those that are necessary. So in looking at that and the recommendations, we need to consider the risk factors for prostate cancer. Clearly, the key one is age. It's a disease that we see the majority of cases in men over 50, but the real risk factor is that of our genetic tray. So a family history, and this is first degree relatives, of 1 or 2 significantly increases your risk, but also there are genetic predispositions. And this is important now because it's not just the prostate cancer. We can see in the BRCA1 and particularly 2 genetic trays, when family members have a breast cancer history, that the male family members have an increased risk of prostate cancer and a more aggressive phenotype. We see that with the mismatch repair genes, we see it in the Lynch syndrome. So there's a number of genetic disorders that we need to be aware of that can give men, unfortunately, a high risk of developing prostate cancer. And then there at the bottom is some of the elements that people often ask about, and I'm sure you get in consultations the questions about what can I do to prevent it. There's nothing that there's clear causal, but there are certainly associations. There's a link with inflammation and prostatitis. Certainly if we control lifestyle factors in terms of cholesterol and sugar, we know that they can lead to better outcomes for prostate cancer patients. One that's often run out is ejaculation protective, and there are some studies which suggest this, and cycling is often talked about for PSA screening, something that we just need to be considerate of. Smoking is not a clear a risk factor for prostate cancer. So if we look at the guidelines, and there's conjecture around this, particularly given that the College of GPs don't recommend a PSA screening, we look at the NHMRC, we look at the Prostate Cancer Foundation, the Urology Society, and really it's quite clear that we think that men over 50 should be screened for prostate cancer with a PSA. The key component here is that it's men who have a 7-year or plus life expectancy, and that is done every 1 or 2 years. DRE is to be considered, and these tests should be offered to men so that they are aware of and they can make the decision around their risk for prostate cancer. But what's key there also is if there's a family history or genetic predisposition, We bring that back into their 40s because that's where we often see the earlier diagnoses and more aggressive phenotypes. And one of the other considerations is one PSA the same as another PSA, and it's actually not the case. And this is often a question that we see from students where they say, well, the normal PSA is 4. Well, there are lots of elements, and I'm sure we've all seen it on the pathology results, that there are age range values that we need to be considerate of, but there are also prostate volume-based considerations and ethnicity-based considerations. And then we utilise some of the other tenets of that. So what's important for diagnosis and what's sort of come out of this now, so we're a bit better in terms of finding the more aggressive and less aggressive phenotypes. MRIs have been around for 10, 15 years, and this has almost replaced the DRE, although not quite. Biopsies with targeted systems through the perineum, so we have reduced sepsis rates. We can actually co-locate these on MRI and ultrasound. PET, which has previously been used for diagnosis, there's a big study in the European Urology Journal from Australia actually, which shows that PET's going to be the newest thing to help diagnose prostate cancer in those sort of areas of conjecture where the MRI is not that relevant, and we talk about genetics there at the end. So I think the key components that have changed in prostate cancer management in the last 10 to 15 years has been active surveillance for low-grade cancers. They don't need treatment. What's developing, as you can see and you know about, the robotic surgery is a really good platform for lots of different cancers and streams of surgery, and that's certainly the case for prostate cancer. And what's emerging is focal therapy, where we can ablate just the cancers and using the accurate imaging at the moment. And thereafter, there's metastatic disease that we can control for many, many years, and I'll mention that in the next slide. But there's development of new chemotherapeutic agents, hormone agents, and directed lutetium. So we're using the PSMA to direct systemic therapy. And so what I've just listed there is it's not a disease that's going to cause great problems for the most number of gentlemen in the early phase. Almost 100% of men survive after the 5-year time point. But it's once it progresses outside that, it's still not a short and an acute sort of progressing tumour, but it's something we should be aware of, I think. And just briefly to cover testis cancer, this is generally a disease of younger men. It's the most common male cancer in younger men. And what we're talking about there is the germ cell tumours, which are the malignant ones, not the stromal ones. And you can see the age distribution there. So if we're seeing masses in the testis in older men, it's typically lymphoma. The key risk factors for testis cancer: undescended testes, which were pexed or fixed when children in their early years, previous testis cancer or pre-malignant findings on other biopsies. We can see their family history is also a risk factor, and some of the genetic traits also. One of the common questions I get is about microlithiasis, and previously that was thought to be a risk factor, but there's been a big US military study, and it is not an independent risk factor outside of seeing a mass. So apart from seeing it, there's no increased need to survey that. But there are lots of ways that we recommend men can screen, and there's lots of platforms out there. Movember have a dedicated awareness page and month, and we recommend men examine the testes once a month, typically in the shower when you're relaxed and you can examine that. And I commonly do that with younger men to explain how they can do that. But the presentation is more commonly a painless mass or swelling in the testis, with the differentials typically being an acute inflammation when it's painful. Diagnosis really based on examination and ultrasound, and then staging with tumour markers only if we find the disease. So these are not used as screening tests, they're used as staging tools in terms of the alpha-fetoprotein, beta-HCG and the LDH. Typically treatment is with an orchidectomy, and then treatments are based upon whether it's just in the testis or beyond. Ideally, and typically in Australia, we just survey this disease and only offer chemotherapy if it's more advanced or recurs, and surgery is also reserved for that element of disease. And the good news for testis cancer is that it is perhaps one of the best cancers that you can be diagnosed with if you had to be diagnosed with one. The survival rates in the short and longer term are extremely high, and this is what I tend to try to convey to my patients, even though they often have a diagnosis at a young age and they're anxious about it. It is certainly a disease that has good treatments and curative rates. So that's been a quick spin through prostate cancer and testis cancer in terms of screening. And if there are any questions, we'll go from there. So thank you for the opportunity to speak today.
We are eyes. We never stop searching. We are hands, warm like blankets and still with certainty. We are ears, loud or soft, we always hear. We are feet, carrying us on your journey. We are arms, always ready to fight. We are the fuel that supports body and mind. We are the brain. We'll never give up trying to understand. We are the heart. We beat with one purpose. In an Australian first, MQ Health integrates world-class clinical care, teaching and research with one goal in mind: to deliver the best for our patients and our community. We are MQ Health.
All right, welcome back everyone. Once again, a big thank you to all our speakers today, Jaiti, Henry and Ben, for all the insightful talks on cancer screening and prevention and treatment in men. Now we'll go into a bit of a Q&A session, so if anyone has any questions you'd like to pose to our expert panelists, you can pop them into the chat box, and we'll post this to our speakers today. So the first question that I have here for our panel is someone asking about aspirin. And so I've been told that taking regular baby aspirin can reduce my chances of getting bowel cancer. And I think, Henry, you covered a little bit about this in your talk. Do we know any proposed mechanisms for this? And should I then be taking aspirin every day?
So I think we still don't know fully how it works. So it's basically aspirin with also some selective non-steroidal medications. And the strong evidence is really for patients who have either polyposis syndrome, so they've got lots of polyps in their bowel for whatever reasons. But in the preventative sort of general population recommendations, we can say that from big population studies, probably in those that are between 50 and 70, there is some benefit. How does it actually work? We probably wouldn't know for sure. But a lot of the patients in that age group are probably taking aspirin for other health reasons anyway. But I think it's important to just have a chat with your local GP, because there are dangers with taking aspirin, even at low dose. So patients who have stomach problems, patients who have bleeding tendency, allergies to aspirin, if they're already on blood thinners for something else, then the benefit is probably going to not, the risk is probably going to outrisk the benefit. So I think it's something that, if you're already on, it does have that benefit. But I think specifically just to take aspirin without any sort of context is probably not recommended. Yeah.
Thank you. All right. And I'll move on to our next question. So someone has asked that I've been told that I have a lot of sunspots. Are sunspots a type of skin cancer? And does this mean that I have a higher chance of getting melanoma?
Sure, so that's a really good question. So sunspots, usually when a doctor says sunspots, they're normally referring to actinic or solar keratoses, which are, in simple words, superficial sun damage. So your skin has developed some sun damage, and what happens is if we leave the sunspots and don't treat it, it can go deeper into the skin, and usually it causes a squamous cell skin cancer. So your local doctor or a skin cancer doctor can prescribe you some cream if you have lots of sunspots, but if you're only having a few sunspots, they can actually freeze them with the liquid nitrogen therapy. Usually the aim with that is to get it back to completely normal skin after a few weeks. If you find that your sunspots were frozen and they haven't gone away, you need to go back to your doctor and make sure that this isn't a sneaky skin cancer.
Thanks, Jaiti. So next question I have, probably more for Ben then. So this is a question around, I get a PSA test every 2 years with my GP, but with the advances in imaging such as multi-parametric MRIs and PET scans, should they be doing a rectal examination on me every 2 years?
There's a lot of debate around that, and what was in the recommendations is that a DRE should still be considered, and there is still certainly a role for it. PSA is a good test, but it's not a perfect test, and there are examples, and certainly it's not uncommon that men have a normal examination and will still have prostate cancer there. So if there's any suspicion, and there are nuances to that in what's the PSA kinetic, is it rising, is it doubling, what is it relative to the size of the prostate? I think there's a role for doing a rectal examination, and I certainly do it with all my patients because it's the richness of the information. It's not just one piece of information. And then coupling that with your risk factors, if you need an MRI or you need some genetic screening with a family history, I think it's using all those elements of information to counsel patients appropriately.
Thanks, Ben. All right. So it looks like that's all the questions that we have for today. So once again, thank you everyone who has tuned in today, and this will also be uploaded online separately at a later date for those of you who want to watch it at a later time. And we'll close from here.